Welcome to the fourth Fracture Prevention Central webinar in a series of 6. Fracture Prevention Central, brought to you by the National Bone Health Alliance, is made possible through support from Amgen Inc. and Eli Lilly and Company Inc. Today's webinar, Case Study, FLS Implementation in an Orthopedic Practice Setting, is co-sponsored by the National Bone Health Alliance and the American Orthopaedic Association Own the Bone program. I'll now introduce you to David Lee, the Executive Director of the National Bone Health Alliance. David?
Thanks so much, and welcome everyone to the fourth in a series of 6 webinars we will be sponsoring through the end of the year. Really pleased to have everyone on the line today, and really pleased to be co-sponsoring this with the American Orthopaedic Association Own the Bone program. So just before we get started, just a little level setting for folks that may not be as familiar with the Fracture Liaison Service model of care. So it's a coordinated preventive care model that has been in operation for over 15 years, both here in the U.S., also internationally. Essentially, it coordinates post-fracture care through a Fracture Liaison Service coordinator who ensures that patients who fracture receive appropriate diagnosis, treatment, and support after a fracture. Also, make sure that those folks are tracked through a population registry and then establishes processes and timelines for patient assessment, follow-up, and care. The great thing about all these programs is that they've all showed not only reduction in the number of recurrent fractures, but then also have also generated cost savings. So really pleased to be able to highlight this model of care to everyone today. So also just wanted to mention really quickly the Fracture Prevention Central resource. So this is an NBHA initiative that was launched in March. We now amazingly have over 1,200 registered users of these tools. So essentially what we were able to do is to work with the national and international programs who have been willing to share their tools and experiences with us. And then I think it really lays out very clearly the elements of the model, how you set it up, how you make that case to set up an FLS in your institution. So really pleased to see how the community has gotten behind Fracture Prevention Central as a central resource center for helping to start, improve, implement FLS programs. So with that, here's my contact information should people want to connect through to us. As I said, we'll have 2 additional webinars through the end of the year. The 3 previous webinars and this one in about a week will be available for on-demand viewing. So certainly hope you can use these tools and resources as you look to set up or improve your existing Fracture Liaison Service program. I'd now like to turn the meeting over to Ashley Lamott, who is the Associate Program Manager at the American Orthopaedic Association Own the Bone program, who will give you an overview of Own the Bone, and then we'll introduce today's speakers. Thanks so much.
Thanks so much, David. Get my slide up here. The Own the Bone program was designed by the American Orthopaedic Association to address the treatment gap highlighted in the 2004 U.S. Surgeon General's report on bone health and osteoporosis. The AOA members really saw themselves as the ones treating fragility fractures at a really unique position to positively affect the care of their patients in dealing with this issue, and really taking advantage of this teachable moment when a patient is in with a fragility fracture to talk to them about the things they can be doing to help prevent their next fractures. The AOA piloted Own the Bone in 2005 and 2006, and the results were published in the Journal of Bone and Joint Science. The program was officially launched by the AOA in 2009. Own the Bone provides the tools needed for institutions to establish a secondary fracture prevention program in order to help identify, manage, treat, and track their osteoporotic fracture patients. To date, we have almost 12,000 patients who have been enrolled in the program, and over 80% of those patients have received counseling on our 10 evidence-based prevention measures, which include calcium, vitamin D, exercise, falls prevention, smoking cessation, limiting alcohol intake, recommendations from their physician on getting a bone density screening and pharmacologic therapy, and then also helping to bridge that treatment gap, so a letter to the patient directly, and then also one to that patient's primary care physician in hopes of continuing that care. Own the Bone offers institutions that enroll in the program access to a national web-based registry, the ability to document, track, and benchmark their patient care, and also document their performance on quality measures regarding osteoporosis. We offer a third-party recognition on their quality improvement efforts. There's a sample actually of that in the handouts that we provided in the conference materials section. That's just the most recent recognition we did when U.S. News and World Report's Best Hospital Guide that just came out. It also provides access to best practices materials and patient education, and also public relations and marketing tools. Currently, we have over 130 institutions that have enrolled in the program. In addition to orthopedic practice groups like the Orthopaedic Associates of Michigan, who we'll be hearing from today, we have hospitals, health plans, and skilled nursing facilities that have enrolled in the program. Currently, 44 states have own-the-bone representation. And I've just got my contact information there. Our website's ownthebone.org, and there's some information in the handout section as well about the program. And then I'm going to introduce our speakers. Dr. Jones is a fellowship-trained orthopedic traumatologist and clinical professor at Orthopaedic Associates of Michigan and Michigan State University. He championed the establishment of a subsequent fracture prevention program at OAM and is currently the principal investigator of Own the Bone at the institution. Dr. Jones was named a 2012 Achievement Award winner by the American Academy of Orthopedic Surgeons for his contributions to education, research, and advocacy in orthopedics. He was listed by Orthopaedics this week and was named one of the top 29 orthopedic trauma surgeons by his peers. He was published and given multiple presentations and instructional course lectures regarding orthopedic surgery and osteoporosis. Dr. Sietsma has been a nurse for over 30 years and held various positions. She is the Orthopedic Trauma Clinical Research Director at Orthopaedic Associates of Michigan and co-developed their bone health and osteoporosis program and assesses and evaluates patients daily that are enrolled in their trauma studies. She is also a professor at Michigan State University and the Van Andel Research Institute. She is an active member of several organizations, including serving on committees at NAN, the AOA, NOF, the U.S. Bone and Joint Initiative, and OTA. And with that, I will hand it over to Dr. Jones.
Thank you. I am proud to be part of this webinar and actually to have the team of people that we have here at Orthopaedic Associates being, I think, I would say, joint partners in terms of this process. And we'll talk about how we have started our process here in Grand Rapids, Michigan, along with Dr. Sietsma. So the steps to success are many. You really need to identify some champions or people who find this to be important. You need to have a mission that is doable and what you want to do. And then you need to access the community resources to try and achieve this. You need to determine a model that's best for you. As everyone has talked about, the Own the Bone program goes from individual private practice groups to large hospital centers and systems. It's the model that needs to be transformed or changed for each one of these to have an appropriate functional plan. A business plan really is required in order to have the bean counters or administrators understand things from a nuts and bolts component and how much it's going to cost. If you break even, this is actually a good program. It's doing what's right, and you're not losing a great deal of money doing it. I think for time it's going to do very well. And with this, you are going to then convince the leadership of what the right thing is to do for your patients and your practice. You need to engage a multidisciplinary team, which goes from everyone from a secretary to a physician to the referral sources and to the patients in terms of developing this program. You need to initiate an advisory council, which will help your program determine which benchmarks you hit and how you're doing as a whole. And I'd have to say from our program, we've had several iterations of how the program is run based on things that develop with time. So you really need to take a continued look at how things run and how they're doing well and where you can improve things. Then, of course, from there, how you implement it. And again, that for us can change on a quarterly basis. From this, you need to track the quality data, and that's where Dr. Sietsma has come into play very well from us. You're only as good as your last patient, and follow-up is quite humbling. And you really can then determine how well you're doing in certain areas and where other areas you can improve on. This council meets, reviews, and revises things, as I stated, almost on a quarterly basis to kind of keep you up to date and to keep things on track. And then you need to expand to meet the needs of what your community and what your program starts with. For us, we started with 1 nurse practitioner. We're now at 2. We were seeing certain patients before. Now we're getting everyone employed, and that really takes a great deal of people marching in unison to get this working. So for us here at Orthopaedic Associates, we're a very large private single orthopedic practice at 34 plus physicians. We have 2 nurse practitioners which coordinate this bone health program at either one of our offices and covering both hospitals. We have 2 MAs and 1 scheduler to help coordinate and run their life from this. There's a great deal of paperwork and coordination that's required to get patients in, and you really need some people on the ground to make sure that this works well. Dr. Zietsma is the PhD which coordinates the research and really, I would have to say, quality program of what we're doing well. She also integrates this with the Own the Bone program to see how we're doing in a comparison factor to other programs. And then if it works well, you can coordinate the physical therapy, occupational therapy, and of course the IT or computer people, which is really required to do the coordination of all these different people and how they work in unison. We're somewhat odd in the fact that we're associated with a level 1 and 2 trauma centers, so we've got a variation of both high energy and low energy patients. Also, we have a very large referral source of what we work with. Steve Jobs said this very well, and I was able to coordinate this into the talk, that you need passion or champion in order to achieve success. It's so hard in the past so long to be successful, and this is a successful program, that if you have no passion for it, any rational person would give up. And for us here, we're now going on 6 years with continued effort, again on a quarterly basis to keep us going into failure. And we move with the punches, so to speak, in terms of how we adjust things to get things just right. You need perseverance when it gets tough. You need to be a great talent scout in order to form a great team of great people. The people on the team here make this work very well. When you have a weak link, it creates problems. And this talent scout component of getting the right people really allows us to move against inertia, which has been the biggest problem for osteoporosis and geriatric fractures as a whole in the United States. The rationale from this is really to provide comprehensive patient care. We do overall a very poor job at this without getting into that. So we need to improve the care of these patients. The Own the Bone programs improve that a great deal when the orthopedist is involved and bringing it to a priority of when patients have poor bone quality. It should be efficient and effective. You really need to improve the fracture healing in complex and challenging patients. For me, the light bulb went on at one of the meetings in the past looking at why patients didn't heal. And a great deal of them, almost a third, did not heal just based on metabolic reasons as a whole. So if we get into just the complex patients not healing, now you're looking at everyone who has poor bone to begin with who fall. We really need to do a better job overall as orthopedists and as a country taking care of these patients. And from that, we also want to prevent subsequent fractures and falls of these patients. And the biggest thing also then is attrition. A lot of these patients, once the fracture is healed, they don't have the pain and they go on as nothing happened, knowing that they're a ticking time bomb, that they can potentially fall again and have another fracture. So the more that we maintain these patients within the program, the better they should do. For us here at Orthopaedic Associates, our Fracture Liaison Service mission is to provide comprehensive orthopedic health care, including osteoporosis, which has screening, diagnosis, treatment, therapy, education, and research. And with that, I'd have to say quality, trying to get that as our main goal. We want to promote bone health, reduce the risk of fractures down the road, accelerate healing, and prevent subsequent fractures from there. Our goals then really are to identify and treat all patients over the age of 50 with a fragility fracture, assure appropriate follow-up is done through fracture healing. From there, we can potentially hand the patients back over to their primary care doctors if they want. If not, we'll continue to take the lead with this. We want to improve bone health-related lifestyle and behaviors and really have persistence in terms of trying to have this continue with them throughout the rest of their life. Decreasing falls with occupational therapy and physical therapy. Decrease subsequent fractures both from a metabolic and a physical standpoint. Decrease the morbidity and mortality that ensues or comes about with these fractures. And hopefully down the road, we as a whole in the United States can overall decrease the healthcare costs that's associated with these injuries and the overall suffering that occurs with fractures.
Well, thanks, Cliff. I will continue here by taking a look at our role in breaking the cycle with this multidisciplinary bone health program and utilizing a fracture liaison service. So if you see the cycle on the right there, where the orthopedist is involved in fracture care following a fragility fracture that has been caused by low bone mineral density or osteoporosis, and they move on to their recovery and rehab, well, what happens next? Well, in many cases across the United States, at least about 80%, there is no follow-up. But with a fracture liaison service, you have opportunity from the inpatient basis where the fracture has occurred to begin this coordination of services and to do an evaluation followed by education and treatment that the primary care provider can certainly take a stand at this point and assist so that all involved then can work towards increased bone mineral density and decreased fracture risk. So in our program, from the very start, in addition to the mission that's already been mentioned, we thought that there were some components that we wanted to tie it all together. We wanted to be comprehensive and be prepared for that, be collaborative, both internally and with those externally, and certainly with our patients. Have a coordinated effort, so coordinate with the goals of the surgeon between the fracture liaison service nurse. We want to be coordinating with PT and OT in terms of fall prevention and core strengthening for the patient, and a coordinated effort with the family that helps support the patient as well. We want to be consistent in how we carry out our plans and competent in staying up with the knowledge and improving quality as we move forward. So one of the next steps was to assess our community resources and what was already here so that we were not duplicating efforts. As you see in the picture, we have several medical buildings right in this key area of Grand Rapids. And we are right in the midst, right next to the Level 1 Trauma Center. So what we learned is that the hospital had several DEXA scanners throughout the community as well as primary care practices. So we negotiated with them to assure that they were all at the same level with vertebral fracture assessment ability and having IFCD certified people to read the scanners. So that way we partnered with them to utilize that service rather than duplicating services. We also found that classes were being provided by the hospital for prevention, but they weren't really appropriate for our patients having fracture. So we do most of our teaching one-on-one with the patients. Primary care physicians are certainly in the community and seeing many of these patients, but again, the follow-up was not consistent, and we felt a need for our orthopedic fracture patients to have improvements in their bone health. So we needed to then determine the model that we would be using. And if you look at the models of care in Osteoporosis International from the author Ganda, identifies through a review of literature of 4 different models that are being utilized internationally. And so the first model is the one that we employed at OAM here. that we, through a fracture liaison service, are identifying patients and then assessing them for both secondary causes for osteoporosis as well as primary following fractures. We're counseling and teaching them, finding that that's a key part of the role in meeting their needs, and also treating the osteoporosis in a coordinated and a comprehensive fashion. So what are the primary roles, or what is the job description, so to speak, of this nurse practitioner? We now have 2 of them who are performing this fracture liaison service. Well, they have primary responsibility for case finding, even though those orders are being automated to them at this point. They plan, develop, assess, initiate, and evaluate, and go through the process with counseling, teaching, prescribing what's appropriate for the patient, developing an individualized education plan that meets that patient's needs for exercise, nutrition, and follow-up. They're generating referrals as appropriate to PT, OT, and then consultation for the complex patients to endocrinologists. They continue to monitor follow-up, data management in terms of getting the information for On the Bone and the registry, and then monitoring the quality with the remaining advisory console to make changes as appropriate. Developing a business plan was important in starting our program. On the Bone was not available to us at the time we started our program, so we started very simply in looking at the previous year, how many fragility fractures there were, how many we anticipated capturing in a bone health program, how many referrals we thought we would make to PT and OT, which we have internally as a part of our practice, and then simply looked at the revenue for each of those intended visits and where we thought we could, and what the expenses would be for the team that would be involved. At this point, however, On the Bone has an economic impact calculator that takes into account from state by state, by the types of mix of patients you have, the types of services that you provide. So you can use this initially as you start your program, and then perhaps on an annual basis as you're looking at improvements and changes and how that might change your potential for increased revenue as you continue to improve your program. So our next step was then to convince leadership. And of course, it's the right thing to do is the mantra that we need to follow, but why was it so important for an orthopedic practice? Well, we were closest as the sentinel event, the teachable moment. They've just practiced. They've just fractured, so it is time for us to step in and see what we can do to make a difference while they are anxious to make that change. We can improve healing and prevent non-unions and complications potentially by improving bone health. We have that responsibility to break that fracture cycle that I showed previously. We demonstrated that we could operate in the black, although it is not a huge moneymaker, but doing the right thing can certainly help in other ways, and gaining more revenue through PQRS, and also being prepared for other regulatory requirements ahead. And just having positive public relations is also very key. So it's important to have an entire team on board as well as an advisory council. All of these people are not on the advisory council, but recognizing that all of them have a key component to making a difference for that patient. Integrating our electronic health record, we utilize NextGen and certainly billing to assist us in the whole revenue cycle of this process. So you see a sample of the template that we've created in NextGen, and it captures all of the necessary components for assessment in the clinic visit. This also assists with PQRI data and data for the On the Bone registry. We have billing codes built right into the template that can be selected from a list for the nurse practitioners, as well as utilizing billing to assist us with the appropriate codes as we move forward. We implemented our program in fall of 2008. We had this ad in the local papers about osteoporosis connected with World Osteoporosis Day. And then we also started On the Bone when that was initiated in June 2009. How does our process work? Well, inpatient fragility fractures is one method. Secondly, we see patients that have perhaps gone to the emergency department and were discharged or through urgent care. We screen them through CPT codes of those coming into our clinic with fragility fractures if they were not inpatients, and then schedule them for a visit. And then lastly, referrals can be from other physicians in the community, by patients themselves, or family members who subsequently think that they also need evaluation as well. The NP, through the Fracture Liaison Service, then evaluates and treats, and every visit we send a letter to the primary care physician. This is an overall view of how the inpatient process works. Ortho consult by both the surgeon and the nurse practitioner, Fracture Liaison Service, through screening in the hospital, establishing the protocols that are initiated, and then on discharge, instructions setting up outpatient follow-up in the clinic and having the DEXA scheduled as well, and coordinating PT and OT when that's appropriate, and then moving on for On the Bone quality and research with that letter as I mentioned. So Ashley in the introduction mentioned the 10 measures of success for On the Bone. We implement each of those as a part of our program, and that this just reiterates that list that was already indicated. So as a part of On the Bone, as well as our own measures, first of all, we look at our continuous volume and the intake that we have with that on an inpatient basis and follow-up, how we are doing with persistence in that, and the revenue. Then secondly, I'm showing you a couple samples of what we get from On the Bone and tracking our quality and looking at where we can improve. This is another sample of BMD testing, and it's comparing us to all others that are part of On the Bone. So you can see in terms of many are performed, and we also planned and scheduled, and of those that were planned and scheduled, at least 73% were followed up by the first visit to the clinic. And that is really our goal, and we're seeking to improve that as well. The advisory console meets, reviews, and revises, as we mentioned previously. When we first started the program, that group met monthly so that we could get through the protocols and approve them, so that it does not have to then be approved on an individual patient basis for the Fracture Liaison Service. The protocols are then followed up, and then we meet quarterly to review other processes as well. We continue in this stepwise process then as in the steps to success to expand to meet the needs. So if we look at where we began in 2008, we started with 1 NP. Where we're at right now in 2013, we have 2 locations, 2 nurse practitioners, 2 medical assistants to support their work, and a scheduler for continuing office appointments. We started with virtually 0 follow-up to over, in 2012, 7,000 visits per year. And some of those are follow-up visits as well, certainly.
Well, thanks, Deb. That gives us kind of an overview of how we have tried to solve this problem that's occurring in the United States. So some of the potential issues we have is that the fear of the orthopedic surgeon treating osteoporosis. And this is the usual question of, it's not my role or problem, I feel uncomfortable prescribing vitamin D, and so forth. And this is very common, despite the fact that the orthopedists, usually at the top of their class for medical school, they seem to forget some of the nuances or simplicities of taking care of patients from a bone health standpoint. It's not only the technical component, there's a metabolic component that's required from this. The other thing from that is that many people don't want to step on any toes of the primary care physician. I think this is the point where it's not only a sentinel event for the patient where they have pain, it's also a sentinel event for the orthopedic surgeon who can remind or encourage the primary care physician down the road that this is a problem, the bone was soft, and that we really need to intervene. So from that, you really need a site champion which is interested in bone health. I know there are many throughout the United States. I'm lucky to have Dr. Stubbert here, who does spine, who was able to assist at the other office concerning this. I think the Own the Bone program is a nice structural program that gives you the kind of the framework to get things going concerning this. The Own the Bone program is very good in terms of allowing you to learn from others, from other mistakes, other inputs, and so forth, getting all the care plans. It's an NP coordinated program, which I think is a great middle-of-the-road program. These NPs do a super job of being a liaison between the patients, the primary care doctors, the family members, and the orthopedic surgeons. And I think the advisory council really is very beneficial also for many of these patients and problems. Potential issue number 2, we've never done it that way. This is usually more of a behavioral problem of where you never thought about the bone health in these patients. Again, for me, my sentinel event was in 2007, understanding that non-unions were related metabolically to anything else, that even just changing the vitamin D was allowing these people to heal. This is a simple type thing. We've created a passive process. The care plans really are beneficial, in my opinion, concerning this. It's one of those ones like the old Life commercials, Mikey, try it, Mikey, Mikey likes it, and it doesn't harm them. It's a simple first step that is really the beneficial thing, as Deb said, to do the right thing. Educating the physicians, residents, and nursing staff concerning how important this is a priority. Seeing someone suffer with a hip fracture at their latter years is not very great for the family or anyone else. The NP does the shouldering of most of the work concerning this, collecting the data, assessing things, determining if the program works well from a structural component since they're dealing with it on a daily basis. And again, I think this establishing the order sets and protocols probably takes care of 97 to 98% of all the patients that come in. This then, when you have variations from this, is the reason why you need an advisory panel and referral sources, such as appropriate rheumatologist or endocrinologist to help you for some of these people that are outliers. As you can see from here, this is kind of a order sheet that is occurring from that on the right side of what you check off and what's required for this. The Own the Bone registry does a great job being a web-based program to plug patients in. And again, from my standpoint, this then allows you to benchmark yourself against prior months of how you're doing and also other programs in the United States to see how well you are doing and where you can improve.
So another potential issue that could arise is the follow-up of these patients. You've seen them in the hospital. The Fracture Liaison Service has done their best to get things initiated, perhaps followed up to try to get the DEXA scheduled, but then what about follow-up? So in our clinic, the follow-up is done right at our clinic with the nurse practitioners. While throughout this entire program, we have been mentioning nurse practitioners, physician assistants, could certainly do this as well. It just so happens in our clinic, nurse practitioners are carrying out this role. And we have selected nurse practitioners because they can prescribe medication therapy and follow up with that too. So follow-up is really key to only identify the patient and then not follow up with the behavioral counseling, determining what are the risk factors and appropriate treatment. We have missed the crux of preventing the subsequent fractures in only identifying patients. So as the nurse practitioners are seeing the patients in the hospital, they really stress the need for future fracture prevention. This is where that teachable moment, that sentinel event concept really comes in. And while we really focus on having the patient come to our clinic 2 to 6 weeks after discharge from the hospital, so we can start that as early as possible and that we can optimize their bone health for the healing process of that fracture. Individualized follow-up plan is then established by the nurse practitioner based on the patient's needs. For On the Bone, there is a 90-day follow-up, and that consistently occurs either by the follow-up in the office, by a phone call, or by a letter seeking additional information so that we can do that by phone. We send a letter to the primary care physician, and for some offices, it may be appropriate then to follow up after fracture healing with other physicians, their primary care, or nurse practitioner in that office who are willing to manage osteoporosis. Another potential issue is, what about the treatment? And some are concerned about all that needs to be known in terms of how do I handle calcium. We've heard issues in terms of heart complications, how much vitamin D is appropriate with all of the different reports that we're hearing. How much calcium do we prescribe in addition for the supplement with the diet? What do we do in terms of bisphosphonates when we're hearing about atypical fractures and other complications? And then there are certainly other options, as you see pictures on the screen as well, from the SERMs to RANK ligand inhibitors and anabolic. Many options. So from that standpoint, our nurse practitioners have been focused and educated in the specific treatment, and their whole role is on the fracture liaison service and just bone health and osteoporosis. They do not encounter any other issues and work on that for the patient. When it comes to diabetes and any other medical issues, that is referred on to their primary care physician. They also do a complete risk factor assessment. The FRAX is integrated as a part of our template tool, and so the results of that can be discussed with the patient immediately during their visit, and they also follow the NOF clinician guidelines. As appropriate, they refer on to specialists for complex cases. Then in this situation, capturing those outpatient fractures. So I already mentioned earlier that we run a weekly computer query by CPT codes and identify those fractures that were not in patients so that we can then schedule bone health appointments for them in the clinic. We do try to provide information in emergency departments and urgent care centers. And so as you see in this handout from NIH, once is enough, a guide to preventing future fractures. So that's really our goal, that once is enough.
The sixth potential issue is making the bottom line. In other words, making sure that your program can pay for itself. I think the On the Bone components of the economic calculator work very well. I think you need to be prepared with a business plan. Starting simple and growing will help greatly in terms of being able to adjust the volumes and start simple before you get more complex. Reviewing the volume and income regularly is very helpful. Concerning how many patients a day an NP can see and so forth during the clinic is very helpful. You need to engage the billing, coding, and IT staff concerning this to make sure you have consistent, comprehensive billing for these patients. And that you also need to coordinate their visits so you can provide the appropriate comprehensive components of making sure that they get everything they need in terms of therapy, the fracture liaison service, and the orthopedic surgeon. And then, as I stated earlier, that your ancillary staff is very helpful in terms of determining the medical necessity with a great deal of letters. Probably a third to a quarter of your program is going to be spent doing these ancillary type things to make sure that patients are taken care of well and that you're able to pay for your staff to take care of these patients. Lessons learned is that you really need to provide recommendations to the primary care physician. The follow-up is not enough. Again, the orthopedic surgeon really needs to determine priorities of these patients who really need to be plugged in. It triples the amount of follow-up from the initial on-the-bone study. Looking at this concerning how many patients are appropriately treated from there. And then when your primary care physician is overwhelmed with some of this, I think the orthopedic surgeon can unload a great deal of the care for these patients to get them to heal without stepping on any toes and being able to have a successful handoff without a fumble or feeling like you're stealing their patients or so forth, that you really can be on a team to provide the best care for this. And in my opinion, the fracture liaison service really does a great job of jumping or leaping this gap. They improve the coordination, and I think that, again, the orthopedic service is the best equipped to determine the initiative of which patients should be plugged in and moved along from there. Identification is not enough. You really need to determine strategies for follow-up to decrease subsequent fractures. And again, as I stated earlier, to determine when patients need their follow-up with education, because once the fracture's healed, they don't find it to be as much as a problem. Again, knowing that they're ticking time bomb, that they can potentially have another fracture and suffer from that. So at this point, we can now have questions concerning our program or your program and where we think you can be advised concerning this to provide the best care to your patients.
Okay, so now it's time for questions. So if you wish to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. If you wish to ask a question live via the phone, press *1 on your telephone keypad. I will announce each caller prior to bringing you into the conference. Please remember, if you have your phone on mute, take it off mute when you are selected to ask your question. Once again, to ask a question via the web presentation, select the chat pod located in the lower left corner of your screen, then type and send your question. To ask a question live, press *1 on your telephone keypad. And there are no phone questions at this time, so I'm going to turn the program back to David.
Thanks so much. And I do see that there are a couple of questions that have come through the web. The first one I can take really quick, which is a question about whether the slides will be made available for review. So when this goes on demand, usually that's within about a week or so. Among the pieces that will be available will be PDF versions of the slides. So happy to be able to provide that. That should be up in about a week. And now I can go to the questions, which the first one is directed both to Deb and Cliff. Let me see. One of the obstacles I'm having is educating patients on the importance of treatment. Many patients believe that because their PCP has not suggested treatment, they must not need it. Since I'm the newest provider in their lives, it is challenging to establish trust and convince them that aggressive therapy is needed. Any suggestions?
Well, I think that the orthopedist is, again, very important concerning this from two standpoints. One is we have a relative component of being able to determine what the bone looks like on the x-rays and what the fracture pattern is. And the second is when we operate on patients, we know exactly what the bone's like if we drill into the bone and do other things. So if the orthopedic surgeon says, boy, your bone is pretty soft, or your fracture from just tripping over the carpet and resulting in this type of fracture is pretty bad, I think that really behooves them to listen to the physician. But I think, again, at that sentinel moment of their injury, they understand very well when they have pain and that they're disabled, and this group of population usually cherishes their independence. Once their independence is gone and they have pain, I think they listen very well. I think then that requires some coordination and education concerning the nurse practitioner, concerning rounding up the labs that are required to convince the patients, this includes the DEXA, that their bone is poor. And I think coordinating that with the orthopedic surgeon, you then can create some trust with the patient and the family, and it's usually the family members who see themselves 20 years younger going down that same path as mom or dad with a fragility fracture, and then also coordinating that with their primary care physician. Again, in our community, the primary care physicians are extremely overwhelmed with patients. There are not enough primary care physicians in the United States to take care of a lot of the patients, and that's why we have found this to be a priority, and we've shouldered a lot of the burden concerning this, and we're happy to. But this also then allows us to create a handoff to the primary care physician once we convince the patient that there is some required intervention for them. Saying that, I can tell you right now I have a handful of patients who are not going to be told they have osteoporosis, which they think that means that they're old. And that is a tough situation for some patients, and sometimes I have not been able to convince them of that. The other one is the elderly patient who says, I'm too old to be treated, or may have dementia and Alzheimer's. And I think those are actually some of the most important patients to treat because their healthcare dollars that they consume with a fracture and the suffering that occurs with a fracture is very important. So the more that we as an orthopedic surgeon and group can be involved to bring this to the fore, I think the better the patients will be served in the end.
Great.
So to dovetail a bit on what Cliff said, he's really addressing the quality issues of the bone, and this is something the fracture liaison service nurse can really be discussing as well, that it's not only about the density of the bone, but also the quality. And so while the density of the bone may have shown a low bone mass or osteopenia, many fractures occur within this range. And so there can be a great deal of teaching and counseling in that area as well. The fracture liaison service nurse needs to have a skill in motivational interviewing to really motivate these people. Certainly the trust issue, as this person has brought up, is important, but the motivation to change their lifestyles, to persist on medication, is a skill that doesn't happen in just a short conversation with the patient. So it takes a great deal of reinforcement and working from that standpoint as well.
Great. Thanks so much. Are there any other live questions that have come through? If not, I've got some other ones queued up.
No, David, there's no live questions for you.
Okay, great. So the next question, are any of your PCPs apprehensive about letting their patients out of their own practices for follow-up care?
Yes, we've had a couple who really are aggressive about controlling their patients, which I think is great, and we actually think that's an excellent issue to have. And again, we go over two things with them from that. Is one, that we've helped communicate with them concerning what we do, and many of them have been quite shocked about the comprehensive nature and really that the On the Bone program's at the fore concerning this in the United States, concerning the quality of care that's given on a consistent basis for these patients. and that we're not trying to steal their patients, but we're more of trying to get the fracture to heal initially, and once that usually occurs at that 3-month interval, or sometimes more 6 months, we're more than happy to kind of hand over complete care. But saying that, we also are more than happy to act as a intervening person or group when they do have issues or they do have backlogs in their office concerning that, to make sure that they continue to get good care. So I think the communication of what's being done is very important. We're trying to get the fractures to heal. We're trying to prevent secondary fractures. And then the communication of how we can best serve that patient down the road can occur. And stating that, we have had some interactions that have been extremely good and helpful, and it's interesting that some of those groups initially were very apprehensive, now are very happy to hand over all their patients because they know that they're getting good care with the On the Bone program. We've had just a very small minority, I would have to probably say 1 or 2 physicians, period, who still wanted complete control with us not initiating anything at all. And we know who those physicians are and who their referral components are, and we make sure that we earmark those patients to make sure that they're plugged into their office early rather than later.
Gotcha. Thank you. Dr. Ciesman, anything else?
No, we can move on to the next question.
Okay, great. And this is just an informational question. So your total visits last year were 7,000. Is that just MP visits, or does that include surgeon visits, DEXA, et cetera?
That is visits to the fracture liaison service only.
Gotcha. Okay, thank you.
That does include follow-up visits, so those are not 7,000 individual patients.
Gotcha. Gotcha. Thank you. And actually, this is a question for Ashley. Ashley, are you on the line?
Yep.
A question about whether there are any community-based coordinated On the Bone programs that involve several private offices.
Sure. If I'm understanding the question right, we don't currently have anyone who's set up in that kind of model, but we definitely have a lot of different models, and we're willing to, we'd be happy to chat with her a little bit more, the one who asked the question, to kind of talk about what her thoughts are and try and see how we can make that work.
Okay, great. And yeah, I can connect you through with that individual person.
Perfect.
So that's great.
Dave,
next.
We generate On the Bone out of a private practice. So On the Bone is not enrolled through our local hospital here at OAM. So it is generated out of our private practice.
Gotcha.
It also shows the versatility of the program, going again from a hospital systems to a hospital to private practice. It really works throughout all of those types of programs.
Gotcha. Great. Next question. You've both emphasized the importance of order sets and protocols. Can you elaborate what those address?
They address initially the consultation to the Bone Health Program and to the Fracture Liaison Service. They include any lab work that needs to be done inpatient. They include stopping any medications that may have been done ahead of time. And in the discharge instructions, it includes such things as scheduling the DEXA scan and facilitating that for the patient, providing information for their follow-up clinic visit and location and timing. And then protocol in terms of if you recognized a certain lab, what would be the resulting treatment. So stepping through potential hypothetical situations or levels and the follow-up of that.
Gotcha.
I think the other thing that really helps with the care plans that I think many physicians don't like, because they think that it takes thinking out of that or individual practice variations. It really, in my opinion, allows this to be a very passive process for people who don't want to be involved, or partners who think that it is a hassle for them. This then kind of takes it out of their hands and makes it almost a passive process in which you know that you're hitting all the main points and getting patients plugged in without forgetting some of these things that you do on a daily basis that you think are mundane but are very important for these patients. And so we make sure that when we do these care plans, then it really is very consistent and it is very comprehensive without letting people fall through the cracks, knowing that this patient population is very difficult. You know, that many of them require people to take them in and out from home. Some are nursing home based, some have lost independence. So having these care plans really allows us to improve this consistency of their care, noting that it becomes more problematic for some of these patients the older they get.
Right.
And the other piece to this is if you've had these protocols approved by your advisory council that has a variance of disciplines, then you're getting support from the key people that may be knowledgeable in this area or can serve as liaison to their section or group of people, be it endocrine, primary care physicians, etc. So they know then clearly what is the plan that will be coming out of this comprehensive care.
Great. Great. So next question related to fall prevention programming. Do your PTs and OTs conduct a formal program? And I guess follow up, do you have any outcome data regarding fall prevention and fracture prevention in your population?
We do have a formalized program specific for fall prevention and core strengthening with our PT. Our OT also looks at fall prevention from more of a environmental standpoint. So they did some specific training considering spine and other areas of the body as well, so that they're looking at the appropriate areas for bending and what's most important. At this point, we do not have any specific measured outcome criteria in follow-up of that, but certainly with each follow-up visit to the Fracture Liaison Service, we are determining whether the patients are continuing to fall, if there's been future fractures, and that type of thing.
Gotcha. Thank you. And it looks like we just have a few minutes left, so let me do one last question. And that is, when the surgeon MP initiates treatment, are they ultimately responsible for the patient once the follow-up is transferred back to the PCP on things like non-adherence, medical management issues? This seems to be a concern of many orthopedic surgeons.
In our clinic, in most situations, patients have desired to continue on in our clinic. And then the nurse practitioner and or the surgeon remain responsible. If the handoff is to a primary care physician and that we have sent, after the healing has taken place, we've provided our recommendation and all of our data in terms of the patient's follow-up and trending, then they become responsible. We certainly agree that there is a higher persistence and compliance with the FLS program than following up in other ways. But each community needs to deal with this in the way that seems best and most appropriate. So sending on those recommendations, then it becomes, and the primary care physician is taking it on, then it becomes their responsibility.
Gotcha.
Also, one other point for that quickly is that we've seemed to have, with the one-on-one components of the Fracture Liaison Service and the NP, seem to have generated a great deal of buy-in from the patients, and there seems to be much better adherence concerning such things as teriparatide or Forteo, which is not great. They look at from an injection standpoint and so forth, and the nurse has done a great job of teaching them, going over things one-on-one, follow-up components, and our adherence to the teriparatide, I think, is over the 90% mark at the one-year interval, which is about 4 times higher than what is noted in the literature concerning this. So, again, I think the Fracture Liaison Service is very, very helpful concerning care for these patients.
Great. Well, with that, it looks like our hour is done here. I just want to thank everyone, the speakers certainly for their participation, the Own the Bone program, as well as everyone here on the line today. And as I said, in about a week or so, the on-demand version of this webinar will be available, and would encourage you to take a look at that and certainly tell your colleagues about this webinar, because I think it really providing some great tools for folks on how to set up an FLS specifically in an orthopedic setting.